Dagwagi Indigenous cause, Washa Sheep and Dodem. So my name is Autumn Watson and I'm from Curve Lake First Nation. Martin is my clan, and I'm currently working with the Indigenous Diabetes Health Circle as the diabetes wellness worker here in the Eastern region, as shared by our fantabulous communications, our knowledge coordinator, Jessica. So I'll hand it over to you, Caitlin, to introduce yourself as well.
Hi, everyone. I'm Caitlin Lazarus, and I'm the manager of operations for the Diabetic Retinopathy Screening Program. So I will be helping Autumn with the day-to-day operations and representing VLR, Vision Loss Rehab, with this exciting program. Josie?
Hi, everybody. I'm Josie McGee. I'm the VP of Healthcare Innovation for Vision Loss Rehab Canada. My role is to create programs of care, and it's most meaningful to me when I do see that there are gaps in care or service, and we can create a program that can meet those needs. And so I'm here. I'm very excited to be part of all of this.
Fantastic. Shimigwach ladies, really nice to see all the comments there in the chat, because for those of you who aren't aware, when we're on a webinar, we can't see who's in the room. So, you know, by putting your name and where you're from in the chat really kind of gives us an indication of where you're coming from today. So Caitlin, I'll get you to throw up the PowerPoint presentation. Alrighty, so the Diabetic Retinopathy Screening Initiative. So for those of you who aren't aware of who the Indigenous Diabetes Health Circle is, we are. And now I'm going to start to rely on these PowerPoint presentations now that they're up there. So the vision here at the Indigenous Diabetes Health Circle, IDHC for short, is to really strengthen the Indigenous capacity to reduce the impact of diabetes in our communities. So most importantly, the Indigenous people, we want to, you know, provide them with the tools and knowledge and ability to make healthy choices. And what you'll see throughout this presentation here today through the Diabetic Retinopathy Screening Initiative is that this is a really great partnership and hits the IDHC vision you know, to a T. So most importantly, we want to achieve, IDHC would like to achieve our vision through promoting holistic wellness. So we realize that, you know, it's not just about nutrition, but it's that physical, mental, emotional, and spiritual health as well. And we really take opportunity to build on those traditional teachings, right? And what those best practices are. And to really hone in and provide education and resources to our communities. So through the strong partnership with the Vision Loss Rehabilitation Canada, they really have, you know, shown this as a really good best practice to be able to share with our community. And fundamentally, I guess, you know, one of the most important, I guess, foundations to the Diabetic Retinopathy Screening Initiative is that we've really built those strong relationships and partnerships with community, and most importantly, building community capacity in the front lines. So, and that is a little bit of who IDHC is, and blending in terms of the Diabetic Retinopathy Screening Initiative. And I'll pass it over to you, Caitlin or Josie for VLR.
Thanks, Autumn. It's Caitlin. So I'm just going to speak about Vision Loss Rehabilitation Canada. So we are the leading partner of rehabilitation services for people who are blind or partially sighted in Canada. We receive more than 8,000 new referrals and provide services to over 34,000 Canadians of all ages. So Vision Loss Rehabilitation Canada is really committed to serving all individuals who are blind or partially sighted through our certified specialists. And this program is in complement to our core services around prevention. So we have a staff of over 270 specialists who deliver services, and we do that in local communities, at home, telepractice, and we have 44 locations across Canada. So part of VLR strategic initiatives is expanding our programs to go beyond just our core services of, if you have ever seen someone using a white cane to navigate in their community, or if someone loses their vision and they need to utilize a magnifier or a CCTV, VLR does all of those core services with computer assessments, employment services for people who are blind or partially sighted, and this screening program is an enhancement to those services with our partnership with IDHC. So I'm going to start by just talking about what is diabetic retinopathy. From there, we will dive into what the screening program is. We'll talk about the impact and partnerships, and then we will end with doing a demo of a screen for everyone to see. So diabetic retinopathy is a chronic condition that is caused by diabetes. So what happens if you have unmanaged diabetes, or if you have unmanaged sugar in your blood? The buildup of sugar in the eye causes pressure on the blood vessels in your eye to leak. So when the fluids in your eye vessels leak, the eye, this happens to everyone, typically the eye just repairs itself and builds new blood vessels. And diabetic retinopathy prevents the eye from building new blood vessels. So that can cause blurred vision. It can cause vision to come in and out depending on where the fluid is in the eye. So diabetic retinopathy is the most common diabetic eye disease, and 33% of individuals with diabetes show signs of diabetic retinopathy. So we'll talk about the goal of the screening program, but it is to prevent diabetic retinopathy from progressing, because it is a preventative disease. 3.7 million Canadians have diabetes, and over 500,000 Canadians have diabetic retinopathy. It's the leading cause of blindness in Canada for individuals under 75, and early detection and timely treatment reduces the risk of vision loss by 95%. So vision loss is preventable, and by getting screened and getting screened early, it can prevent progressive vision loss. So there are different aspects in terms of reducing the risk of diabetic retinopathy, and we call it the ABCDEs of prevention. So these are items that you can talk to your primary care provider about if you are connected to diabetes education. These are all pieces that can reduce the risk of diabetic retinopathy. So A, it's for A1C, so it's a blood test that measures blood sugar control, and the goal is for it to be 7% or less. B, blood sugar, so the optimal blood pressure, should be less than 130/80. C is for cholesterol, and the goal is to have cholesterol being low, which ties into D for drugs that can help prevent rising blood pressure or cholesterol. E for exercise and eating, so regular physical activity and making sure that we're eating in a way that supports our diabetes. And S for screening or monitoring for complications, and that looks like heart, feet, eyes, kidneys. So screening is really important, and particularly eye care screening is why this program was developed. So why get screened? Screening is incredibly important because sometimes there can be damage to a person's eyes without them experiencing vision loss. So by getting screened early, it can prevent further vision loss or other complications. Changes can be detected incredibly early by the screening program, which can lead to prevention.
All right, is it my turn? So it's Josie here. So I'm going to talk a little bit about the Diabetic Retinopathy Screening Initiative and even how we got here and why we started this in the first place. So part of the reason why we started the Diabetic Retinopathy Screening Initiative is we have an IVAN that does go out into northern communities to provide services, eye care services for clients in sort of more remote geographical areas in the north of Ontario. When COVID hit, we couldn't run the IVAN program. And we had a conversation with the Ministry of Health just discussing the fact that there were still people falling through the cracks. That was only in the north, so we weren't getting to other geographical communities. And diabetes was a big issue in terms of getting those screens for diabetic retinopathy. There is a teleophthalmology program that was currently being used, but it wasn't being used very often or very effectively or very efficiently. And we really wanted to understand why it wasn't being used and what were the barriers for some of these communities to get these screens done for their members. So we had lots of conversations with some of the organizations that we served, some of the communities that we served, and other different stakeholders, just to understand what the barriers were. And there were three significant barriers to providing these screening programs closer to home. One was the fact that in this teleophthalmology program that was currently being utilized, the equipment was very bulky. So the equipment to take the picture of the retina was bulky, a lot of it was at end of life, couldn't really use it. A lot of the individuals had to be dilated, their eyes had to be dilated in order to take the image. It had to be a healthcare professional to do it. So that was one of the barriers. And a lot of these communities, are very remote, or they're traveling, like the healthcare workers are traveling into other remote communities. So taking small planes and things like that and taking a big tabletop camera was not appropriate. The second biggest area or barrier was the fact that once the images were taken, all those images had to be sent to an ophthalmologist. The ophthalmologist would have to review those images, and then they would send a report back to determine whether there was diabetic retinopathy or not. The wait times could be upwards of 2 weeks. So, the client may not have, or the individual may not have that information for a while. And in some cases, the teleophthalmology sites still meant a good 2 to 3 hour drive for the individual to get to a teleophthalmology site. The last piece was in some of the communities, there weren't enough resources or the capacity to then, if a client was identified with diabetic retinopathy, sort of what the next steps were, how to get them referred to the appropriate eye care professionals. So what we wanted to do was find a way to mitigate all those barriers. And so what we did was we found handheld fundus cameras that you will see shortly by Caitlin that can take the pictures of the eye. They're very small, very portable, very easy to use. Less than 10% of individuals need to be dilated. It doesn't have to be a healthcare professional. And the key piece was training individuals within those communities to take the picture. So that program the program could be developed and provided closer to the individual's home. The second piece was finding AI technology, which means we found a software program that you could upload the picture in. It would go into the software, and then it would spit out a report in less than a minute that would identify whether there's diabetic retinopathy or not, how severe it was, whether there was edema, and didn't have to go to an ophthalmologist to review because the AI did that work for them. Finally, what we added was a care navigation piece, and vision loss rehab would take on the role of, so if someone was positive, a referral could be sent to us. We're working with ophthalmologists actually who will review all the positive screens and who will determine whether clients need a consult, which they can do virtually at first. And if they do require care, we would coordinate all that care. The ophthalmologist would help facilitate referrals closer to the client's home and ensure that any follow-up care is being completed. the screens are done sort of within regular scheduled care. That is sort of the whole model of the program. So as I said, Vision Loss Rehab would train community providers to learn how to use the camera and take the pictures of the eye. We also do the training on the software. It's not a very long and involved process. So they take the image, they upload the image into the software. You get that summary report within 60 seconds. You can engage and educate the client right there and then at point of care. If there is a positive screen, then there can be a referral to us, and we will coordinate that care. We will have ophthalmology be looking at that and ensure next steps are taken. Also, if the client is already experiencing some sort of vision impairment and that's impacting their daily lives, we can also provide that vision rehab that Kate talked about in the beginning about what our core services are. Start to finish, it's less than 15 minutes to do the whole process. So it's a very simple process, and hopefully we can get to a lot more clients than has been in the past. So Caitlin will go over more on what this all looks like.
Well, just before Caitlin jumps in to demonstrate the camera and what that looks like, in terms of the partnership with VLR and with the community, there has been a tremendous impact this far. So we have provided presentation to certain Indigenous communities that have really welcomed this as a prevention initiative. So as Josie was mentioning, some of our communities were tagged into telehealth. Here at IDHC, we used to have, one of those big clunky machines, according to my supervisor there up at head office, which I wasn't privy to. So this was, really welcomed as, a hands-on initiative that we could bring to community. So that direct training that Josie spoke to, both Caitlin and I have, hit the streets, so to speak, and reached out to various organizations and communities in the region. And trained approximately about 20 frontline workers. And it's really nice to see some of the comments that came in. So some of those community frontline workers that, did take the training, are in the room here today with us, which is really nice to see. It's this community-based intervention. It really hits the direct need that Josie spoke to, building capacity, and it's sustainable. So I don't think Josie hit on in terms of the life of these cameras, but I believe, correct me if I'm wrong, they're about 10 years longevity to them. So what's really nice is that, the frontline workers are trusted in the community. So this program would not work, without, the community health nurses, the community health representatives, those who have been identified at the community level that already have that trust with, the frontline worker. And so it's left up to community to deliver that in a culturally safe way, right? So, which it will all carry out shortly. So as you can imagine, I guess, COVID has kind of, tried to put a wrench in the spokes of the program. Most importantly, it provides that access to screening. So whether community determines to run that out at a clinic site, or maybe they're having a community wellness day, or at a health fair, it really opens the door for community to be able to gain access right here in their home communities. Again, Josie alluded to this, that those transportation barriers are relieved. I guess they are reduced. And it can be delivered to remote settings. So frontline workers can actually, take the fundus camera, into, a community member's home, should there be any mobility or transportation issues that they're unable to access there. the decreased wait times, as Josie alluded to as well, between specialist appointments. And, sometimes we respect that, community members, go in, do a test, have to go back 2 weeks, and either, they forget, or, the momentum has been lost to take that ownership of their own health. So they miss those, second most important appointments with the specialist. And ultimately, it is reducing the risk of vision loss. And I don't have the figure off the top of my head, and maybe Josie, you can chime in here. You had mentioned that, even prior to COVID, in terms of individuals who do diabetic retinopathy screening, compared to the amount of individuals who are living with diabetes is relatively low. So this program does open that up. So Josie?
Yeah, so I believe there was 500,000 people with diabetes in Ontario, and I think only 2,000 screens were done. That was the year before COVID hit, and that was in all of Ontario. So that wasn't, that was a very small number. And when COVID hit, I think it went down to 200. So we're definitely not, doing the amount of screens that we should be doing in order to ensure that we're catching diabetic retinopathy early.
Yeah, thanks, Josie. So the impact has been huge. And I think, if I can speak on behalf of, the frontline workers that have been trained, was quite positive. So the current partners is Curve Lake First Nation, Alderville, Hiawatha, Algonquins, and Pikwakanagan, Lovesick Lake Native Women's Association here in the Lakefield area, as well as Nogo Joanning Friendship Center, which is the Peterborough site, and the Indigenous Interprofessional Primary Care Team, based out of Tyendinaga, but has more of a regional kind of Eastern approach, as well as some staff at the Community Wellbeing Center in Mohawks Bay of Quinte, so Tyendinaga area.
Wonderful. Thank you, Autumn and Josie. So now I'm going to do a demonstration of the screening program. So I'm going to stop sharing my screen in a second, but there are 2 pictures on the screen. So the first picture is of a staff member taking a screen of an individual's eye. And the second picture is a photo of my eye that I took yesterday. And this is what the image will look like from the camera. So I'll demonstrate it, but that is what the image will look like. So I'm just going to stop sharing. Here we go. And then Jessica, I don't know if you can pin me so there's more room to demonstrate, if that's an option. If not, no problem.
Done. You're pinned.
Okay, great. So yeah, so this is the camera. So when we talk about the screening program and how accessible it is, this is what the camera will look like. It's about a pound and a half. It's portable. It can be, as Josie may have mentioned, to fly in communities. It comes with a carrying case. It can go into people's homes. It's not, a 100-pound tabletop camera that can only serve the people who are closest to that location. So it can work offline as well. The reports do need internet to run, but certainly all of the steps for people who are getting screened can happen pretty much anywhere. And the beauty of it is that this camera has built-in redundancies to make sure that we're getting a good screen. So what will happen when we're doing an appointment? So yes, Adam?
Sorry, I didn't want to interrupt. So there's a comment in the chat that you haven't been pinned to the screen. So I'm just wondering, Jessica, I'm not 100% familiar with a Zoom, if you can walk community through where they have to change their view setting so that Caitlin becomes the screen.
I just changed it to Spotlight, which I think might help. But if not, people should be able to click on the 3 dots in the right-hand corner of Caitlin's picture and maybe hit pin there. But I've changed her to spotlight, which I hope will help.
I think also if you go to the view,
Speaker.
you know, the view on the right-hand top corner, and then there's speaker or gallery. You want it to be speaker. I don't know if that will help. So if you go to speaker.
Yeah, sorry, Josie. I got all excited. I'm like, and nobody wants to miss Caitlin's eyeball. This is an exciting process. Yeah.
It says that's not available.
It's available in this webinar.
Is it like it should be on the top
right-hand corner?
Yeah.
Only in Zoom presentations. Okay, great. So I think because this is getting recorded, so now with being pinned as the spotlight, I'm taking up my whole screen. So I think with the recording, that may work. I'm just also reading.
Maybe Autumn and Josie, if you just turn off your cameras while she's demonstrating, that should help, hopefully. But I think let's move on in the, people are saying yes, so that worked, okay.
Wonderful, okay, great. So, so this is the camera. It is, like I said, about 1.5 pounds. It's easily portable and there's not much to it. There is a docking station and the camera. Yeah, it can be used pretty much anywhere. No need for internet to take the photos. We do need internet for the screens. So how it will work is depending on the partner, depending on the community, every community may decide to do screenings in a different way. So it may be that there is a screening day. It may be that screenings are available as part of a health fair. It may be that if you're going into a foot care clinic, you can also get screened for diabetic retinopathy. So each community, there's so much flexibility, will do screenings in their own way that works best for the community. But what will happen if you are getting screened is the individual will sit down, the person who's doing the screen just sets up, it's very easy. It looks sort of like a camera. Maybe you can see my face now.
Yeah, we can see you.
So what will happen is 4 images are taken, 2 of the right eye and 2 of the left eye. So to take the photos will take 5 to 7 minutes. And then once the photos are taken, the camera is simply docked and we run a report. So I'm going to show you what it looks like. Autumn, are you able to give some running commentary?
Yeah, I just want to confirm with the group that when I speak, my icon's not coming up and disabling anything. Is that correct with community? Can you still see Caitlin? Okay, correct. Perfect. Great. Yeah, I'll walk you through it, Caitlin. Yeah, so now we can see, you know, Caitlin has the image of the eye. So as a frontline worker, you come in and you hone in right there to the optic nerve, so that bright light, and you'll see the sides go green. And when it goes green, the frontline worker will click kind of like a trigger. And so it's fairly, you know, a sensitive thing. So, you know, sometimes it'll pick up red and then it'll hone into green. And then if we need to, as frontline workers, we can back out.
Autumn, you tell me when to take a,
yeah,
because I can't.
When I say green, there it is.
Okay.
Yeah. All right. So we're going to retry. We're coming in and we're following that optic nerve, and that's that bright light. And then as you can see, as it gets captured, it is going to switch green. not yet. You're almost there. And then what happens, sometimes we get in our head. So we're following that optic nerve again. And this is very challenging, obviously, for Caitlin to do this on her own. We've done practice read and bang, bang. And any of the frontline workers who know Caitlin, she does this all the time in the trainings and it's spot on. But she said she was going to be nervous. So shake it off.
Well, and so what happens is, you know, because of COVID, we were planning on doing it in person. I'm not able to see what's happening. So, but what would happen is I would be able to look through and line it up. Okay, here we go.
And there's the optic nerve, and it's green. Green.
There you go. Green.
You got her. You got her. It's going to be a sensitive trigger today. I think you took a picture of your screen. Oh, you got it. No, let's see. You have it, but there might be a little bit of a reflection on that one. Yeah.
Yeah, I pulled away, I think, a little too fast. So we'll try again. This is a learning process for all of us, taking a selfie, if you will. But
yeah, much easier taking it on somebody else.
Yeah. And there's your optic nerve. Green.
There. Oh, to the left of it, or my left. You're right.
I think you might be letting light in there. Green.
There. Oh. It's too hard.
I'll try this way so you can see. So this is what it would look like for it does work better in a dark room. Yes. I'm going to just run and turn off the lights in the room that I'm in. But Autumn, maybe, or Josie, while I'm just running across to do that, can provide some context about what happens after.
Yep.
This one's great.
Yep. So once the image is taken, it then gets uploaded into the software. So there's a laptop that goes with the camera. The software is installed on that laptop. There's a login to get in, and it can be done wirelessly or through a USB port. You upload the image, and then that's when the AI software will do its thing and spit out a report. And as Caitlin spoke about, it does not, if the camera will hold the pictures if you don't have Wi-Fi wherever you are. And then once you're back to Wi-Fi, then you can upload all the pictures that you took that day into the software.
All right, let's give it a shot. The AI, yes, Irina, I can see your question there. So over time, once you practice, you'll learn if the screener will learn if it's a good enough picture or not, but the AI will also say, you know, images not of sufficient quality when it goes in, so it'll tell you the reason. So this is what it looks from a side perspective. So if I were the person getting screened, it's a removable eye cap, so it can get sanitized in between each use, and there's multiple eye caps that go with each camera. So it just goes on, and it's quite soft plastic, so it's not, there's no pressure or anything on the person's eye. So let's give it a shot. So it just sits softly.
And the reason why Caitlin can kind of see what's happening is there's a red dot in the camera that she can focus on, and it kind of widens. So then she's able to see her eye. There you go.
So, oh, you know what? It's not, I can see it on the screen, but I think that my video is making it.
Yeah, it just looks white. That's not what.
Do you have a piece of
I
paper
think it's
to
the
block out the light? Sorry, everyone. We had all intentions that we were going to be in Caitlin's office to demonstrate this, and then protocols changed.
Caitlin, maybe you can just tell us what you see. I can see a little bit of the red at the top.
Yeah, it's
like the picture on your slide.
It's the picture that was on the slide is what you see. You might want to put that up again, Caitlin.
Yeah, so I took that with one shot yesterday. It probably is. I'm a little, maybe I'm nervous in front of people knowing that they're watching me. But it is quite easy. As hopefully you were able to see that the red brackets will turn green when it's lined up. And so there is all of those mechanisms in place. So the picture, I can go back and share my screen so we can look. So this is just a quick picture I took yesterday. So the white, there's a yellowish bright circle with a bunch of nerves coming in and out. So that is called the optic nerve head. The other piece is there's a black blob, if you will, sort of in the center, and that's the macula. So what happens when we're taking photos is we take 2 photos of each eye. So one is with the macula in the center, and one is with this optic nerve head, that bright ball in the center. And what happens is these images go into the AI software, and it compares it to over 2 million images of patients with diabetic retinopathy and patients without diabetic retinopathy, and it's able to pick up the earliest signs. So what will come of the report is either no retinopathy, in which case our recommendation is getting rescreened in a year, mild, moderate, advanced, or macular edema. So if there is a positive screen, as Josie mentioned, that will come to vision loss rehab, and we will coordinate a referral to ophthalmology. Yeah. So the other piece is the coordination. So if there is a positive screen, our coordinator, once we receive the referral, will call the client who got screened within 2 business days to make sure that we are coordinating all of those services. So this is what the pictures look like. And that's sort of, it wasn't the most successful demonstration. It is quite easy. Each photo, takes maybe a minute to line up. And it's 4 photos and then runs a report. So the reason we created this program again is because, only 2,000 screens were done in 2019. And this program gives us the opportunity, to do widespread screening. And the other piece is that anyone can, pretty much anyone can learn how to use the camera and take screens. So it can be done in home communities and here closer to home.
Thanks for that demonstration, Caitlin. You've done an amazing job, as always. I'm not sure what time it is, and we can open the floor to questions, but one of the questions that is probably on many of your minds is cost. So in order to do the screens for the diabetic retinopathy, it is $30 a screen currently. I'll pass it over to you, Josie, to talk about the other form of screens that are $10. But right now, the costs are covered for the screen. So if, the frontline worker, for example, here in Curve Lake, runs the screen, there is no potential costs. So those have been covered through proposals, as well as here at the IDHC. So some of the other kind of factors when we went into community was, a request to, have some additional equipment. So like a roll-away table or a chin rest, just to give the person taking the image a little bit more stability, and or the individual who is receiving the screen. So equipment is being purchased to coincide with each of these cameras when they roll out to the community. And then Josie, maybe what I'll do is I'll swing it over to you in terms of the new the new software that came about once we started rolling this initiative, and the benefits to that broader software that we're going to start to include in the DRSI.
Yeah,
Thank you.
absolutely.
Thank you, Autumn. Yep. Sorry, I was just going to say your video is on, Josie, but Autumn's is off. So when she comes back on, if she wants to put her video back on, she can.
There we go. So yeah, there is another software that we are trialing. We did get some funding to trial this software as well. We started with iNook, which is the software that you see here, because it was Health Canada approved, and it had been sort of in process for a long time, but mostly it was Health Canada approved, which was a big thing. The other software is from France. It is going to be able to detect up to 40 different eye conditions. Part of this testing that we're doing is to see, the validity of it. But right now it can test for screen for diabetic retinopathy, AMD, glaucoma, drusen, and I believe cataracts is coming up very quickly. So that is another option. I think too, as we go down the line, that we could probably hopefully get some reduction on those screening costs as well as we start to really build numbers. But the key piece, and that's my role in this program, is to ensure that we can get this to be funded ongoing. So the ministry is very, they really like this project. We were just at a meeting recently, and they said that this proposal was gold standard, and they were using that as the sort of gold standard for all the other proposals. They're very interested to see the outcomes. We have a lot of support from the Ontario health teams, and it is a quite cost reduction from even normal teleophthalmology, because as we discussed before, all the images had to be sent to an ophthalmologist, whether, every image, right? They just took the picture because there was no AI software. So every image gets sent to an ophthalmologist. Now the ophthalmologists are only reviewing positive screens, which we are projecting to be only 10%. It could be a little bit higher. But even so, I mean, that's a good percentage of ophthalmologist time that's not having to be utilized and not being billed for. So, we want to demonstrate to the ministry that this is, from a patient care or client care perspective, better, seamless, closer to home, preventative, getting, those screens done quickly and easily, not a lot of additional resources needed. So, that whole patient and user experience. And then also from a cost perspective, not only immediate costs, which is there are going to be immediate cost savings, but those sort of cost savings of future cost to the healthcare system as a result of the vision loss that can happen from diabetic retinopathy if it goes unnoticed. Last couple of figures, in the last couple of years, it was $1.2 billion annually that Canada spent on vision loss associated with diabetic retinopathy. So, I mean, if we can, get in there and do those screens, and I think there was a question about whether it could be reversed or, so it doesn't necessarily get reversed diabetic retinopathy, but with, early detection and early treatment, you can sort of slow down that progression, and you can definitely, if you get it at a good time, you can prevent that vision loss that comes with it. So how effective is the screening? So Kate, what are the sensitivity rates and specificity rates again?
So it's 99% in sensitivity and 97% specificity. We do say that it is a screening, not a diagnosis. So I think the second part of that question was risk of misdiagnosis. And this is where our partnership with the hospital in Kingston Ophthalmology and Queen's University through the ophthalmology program and partnership, they review all of the screens. Because it is done by non-clinicians, non-healthcare providers, it's not a diagnosis, it's a screen. So all of those will go to ophthalmology and review it. And if they see that follow-up care is needed for positive screens, that they will either do a virtual consult with the individual or do a referral to the nearest ophthalmologist to their home.
Thank you, Caitlin. We've got a couple of questions here in the Q&A, which I'm not sure if you can see, but I think a key question here asked by Monique is, how can we get trained in doing this if we are interested?
So currently our partnership in the East with IDHC, as Autumn mentioned, we have current partners and current communities that we're working with. We're certainly open to, I think, expanding those communities. We want the reach. We think that everyone who has diabetes should get screened. And that's ultimately the goal. We are, rolling it out currently in the East region and in the North region. So if you're interested, please reach out to myself or Autumn or Josie, and we can look at what that looks like. And I'll put our contact information up at the end.
Thank you, Caitlin. And I will share your contact information with your permission with everyone that joined us here today.
Yeah. Perfect. And just so everyone's aware, the training takes 2 to 3 hours, and then it requires some practice. So it's not we don't want there to be a huge, worry about tons of training. It is relatively easy. I didn't do the best demonstration, but I promise that it's relatively easy, but it takes some practice, as you can see. So probably about a 6-hour, 7-hour commitment, including practice time.
Wonderful. Someone asks, can a regular eye doctor, would they be able to see this? I guess the screens and the results of the screen. Would you be able to communicate that with someone's eye doctor?
Yeah, absolutely. So part of the care coordination that we will do is with positive screens, if there is someone has a primary care doctor, family doctor, if they have an optometrist or an eye doctor, we will send that information. And, this is a screen of your eyes. And in terms of personal health information, if, you want the negative screen to share with your primary care physician, you can let your community partner know. And negative screens can be shared. But VLR does the care coordination for all of those positive screens, and we'll send those to your primary care provider and eye doctor.
And with the negative screen, it's basically you would want to get another screen done in a year's time. Part of the other thing that we're working on with the ophthalmologist is to develop some care pathways, so that there will be, if someone maybe has mild diabetic retinopathy, they might, it might come up that the care pathway is to have another, or when the appointment should be and who they should be with and that kind of thing. So it'll really streamline the care pathway for the clients as well. Someone asked a question about optometry. So yes, optometrists do these screens as well. And if you have diabetes, there is no cost that is covered by, that should be covered by the government if you have diabetes.
Okay, so that's in response to the question of whether the optometrist charges for that.
Yeah.
They may if you don't have diabetes, is that the answer? But if you do have diabetes, it's free of charge. Okay.
Caitlin, were you going to add something to that?
Oh, I was just going to say, and that's part of the impact of this screen and our partnership with IDHC and the funding that we've received, so that there's no cost to the person getting screened, and the referral to ophthalmology is completely covered. So if someone right now wanted to get screened before this program, they'd have to go to optometry, where there's a cost typically.
That's interesting. And I don't, it's just saying that one person said that the optometrist said that they have to pay up front first, even if they have diabetes. I'm not sure about that process. I'm under the understanding that if you have diabetes, there has to be a referral, I think, from the GP, but unless they've changed that, I don't know. Kate, do you know?
No, I think, I don't know, but part of why this screening program was developed was there can be a lot of barriers to care. So, if you think that there is diabetic retinopathy, you go to optometry and then you get sent to ophthalmology. I'm not sure about optometry and charging, but I do know that there, outside of diabetes, is typically a cost.
Yeah, I just went on to sort of search on that again, and from the Ministry of Health of Ontario, it does say, because optometry, OHIP only covers with optometry under 19 or over 65, sort of regular services. The 20 to 64 usually have to pay unless you have something like diabetes. So that's kind of what it says.
Yeah, I think this is a great conversation, actually. Perhaps Josie and Caitlin, this is useful, the chat box, to you to see what people's experiences are. It might give you some information in terms of barriers that community members are seeing.
So it does say specified ophthalmology services for patients of any age with specified medical conditions or diseases affecting the eyes are insured. So they should be insured.
Okay, well, hopefully people will be able to advocate for that, or maybe reach out for support in advocating for that if and
those conditions include diabetes, glaucoma, cataract, retinal disease, visual field defects, corneal disease. So there's a few things that that it should be covered. So.
Yeah, and maybe if I can too, there's going to be resources that are developed in and around the diabetic retinopathy, so in and around eye health. And I think given kind of all the conversation that is happening in the chat, those are kind of, the question answers we can kind of allude to into that resource, as well as, maybe vital links or, who to contact should, some of these challenges arise. So I hear what you're saying, Melinda, in terms of non-insured and the whole reimbursement, even if your status, that is probably based on the service provider themselves. There are service providers out there that will continue to work with non-insured. It could also be further compounded because of all of issues that have risen in and around optometry over the last year. So I think it's probably a combination of sorts. But for those frontline workers and for Josie and Caitlin, just remember, we'll plant that seed to include some of this information in the iResources as we continue to develop the program.
Yeah. And again, that's why we really feel this program streamlines a lot of that, because you can get the screen and go directly to ophthalmology, through the coordination that VLRC will do. So it kind of eliminates some steps, and you don't have to worry about that cost.